Hello, my name is Ignacio Lugones. I'm a congenital cardiac surgeon from Argentina, from Buenos Aires. First of all, let me thank the organizing committee for inviting me to this outstanding meeting. It's a pleasure and an honor to be part of this group, and I think that we are tackling one of the most urgent problems for the pediatric population. So it's a pleasure, really, and an honor to be here. Today, what I want is to share a perspective of that is in some way both professional and personal, which is what it means to train pediatric cardiac surgeons in South America, which is a region with extraordinary talent, challenges, and of course, many interesting and extraordinary histories, stories of resilience. So pediatric cardiac surgery anywhere in the world demands a lot of precision, dedication, and many years of preparation. In South America, our path is shaped not only by the complexity of the congenital heart defects themselves, but also by the geography, the economics, and I would say the healthcare landscape that can be, as I said once, uneven and unpredictable. And yet, despite these barriers, South America has produced some of the world's most innovative congenital heart surgeons, like Dr. Kreutzer, like Dr. Chaten, like Dr. Da Silva, and major surgical techniques and many centers of excellence. So this talk is about how we train, the obstacles. I will try to describe the obstacles that we face, and what I always say, creativity is comes from the need that we have. So it has shaped the way in which we train our members of the community, surgical community, and all this is required to overcome our daily challenges, which are treating pediatric patients with congenital heart defects. And this impacts the lives of millions. So thank you for the opportunity to express how our opinion on how we train and how we should keep on going with this path. Well, the first and most important thing that I want to outline is that, as it happens in many other places in the world, there is no single up to date official registry of pediatric cardiac surgery centers, teams, training programs, or even data related to the population, to the patients that we are operating on in these regions. What we know for sure is that there are many centers that have excellent results, in particular in some countries in which I will be talking more in detail about. But around only 40% of children with congenital heart defects receive surgical treatment in this area. That means that around 25,000 children per year in South America with newly diagnosed congenital heart defect will never receive the treatment that they need. And as there is no concrete data in which we can rely, what we will try to do is gather all the data that is scarce and somewhat not clearly found, but I will try to reconstruct a picture for you and give you an overall view of what is happening here in this region. What is completely clear is the burden of congenital heart disease in South America. And I will read this statement from the Pan American Health Organization issued on 2024, September 2024, which says that I will read, among the leading causes of newborn and under 5 mortality, the second most frequent group is congenital defects. More than 1 in 10 deaths in newborns and children under 5 are due to congenital defects, and among those, congenital heart disease represents the most frequent group. So, as you know, this is a big burden for the region and for many other regions. There are basically two major sources from which we can obtain data related to the global congenital cardiac surgery workforce, and we can focus on South America. There is a 2025 review which described the registrations on CTSNet, which is a very important website for us, and counted the number of surgeons by country. Okay, so these are the results. Argentina, 49 cardiac surgeons, with the total number of surgeons per million children under 15 years of age, with around 4.6, followed by Brazil with 3.5 surgeons per million children, and Colombia and Chile and Uruguay. Okay. Um, these numbers do not really represent the reality. For example, I know the reality from Argentina. We are far more than 49. This is data coming from 2021. But an important thing that I want to outline is that these numbers come from self-registered surgeons on the platform on CTSNet, not from official national registries. Okay, so the authors, in fact, themselves, they highlight that many surgeons, uh, also who register as congenital, in reality may only do some simple congenital heart cases, and the complex neonatal work is concentrated in fewer centers. Okay, so but this is kind of an approximation. Okay, so what we know for sure is that South America has far fewer congenital surgeons per child than high income regions like I would say North America or Western Europe. But despite this data that is not perfect, we have more or less an idea, and currently is one of the best global comparative snapshots we can have. Okay, so important also to note is that we have big intra-regional disparities, as you can see here. For example, in Bolivia, there is 1.6 surgeons per million children, as compared to Argentina or Brazil. So this is something very important. I will describe this in more detail later on. This is the other source, which is from a paper published by my good friend Christian Kreutzer from Argentina and other co-authors from Latin America. This is from 2011. Data is a bit out of date, but here we can see the numbers of surgeons. And as you can see, Brazil had at that time 83 surgeons, Colombia 24, Argentina 31, and 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 the other countries, you can see the numbers there. But as I said, this happens 15 years ago. The data is probably more reliable because this was performed by asking each of the surgeons from each of the countries, or at least the reference centers, and the information might be a bit more reliable. But the problem is that it is a bit old. But anyway, the situation is more or less the same. We might have improved the numbers or increased the numbers of surgeons, but the training programs and the realities of the different countries remain basically the same. Okay, and again, the disparities between countries are still there. So that is very important to note. Well, and here you can see the broad training pathway, how it looks like, with, of course, country to country variations. But in general, the pathway is this one. After medical school, which is usually 6 years, there is a general surgery and or cardiovascular surgery residency, which is typically around 5 to 6 years in total. And then comes the subspecialization or the fellowship in pediatric or congenital cardiac surgery, which is usually around 1 to 2 years in a high volume reference centers, sometimes combined with some time abroad, like in Europe, North America, or even in other countries within the region. And there is a strong tradition of apprenticeship and mentorship. For example, we have the Kreutzer School in Argentina, in which I trained, and there are other regional pioneers. And this has been historically more important than, I would say, formal, broad, certified pediatric cardiac fellowships. And of course, we have the regional differences that I outlined before. Argentina had always a very strong surgical school. The origins were in the Kreutzer family. It began in the 40s and the 50s with Finocchieto, Albanese, Brea, and Tricheri, but Rodolfo Kreutzer, Billy's father, was the first, I would say, a dedicated pediatric cardiology, created the first pediatric cardiology service in 1936. And he was one of the most important cardiologists of South America at his time. And in fact, he did an orthography with a dye injection at that time, very early. So he focused on rheumatic fever, on ECG, angiocardiography, and he wrote a textbook in Spanish at that time. The small picture that you see on top is the book that was written by Guillermo Kreutzer describing the history of pediatric cardiology and cardiac surgery in the region. The picture that you see here shows Eduardo Galindez and Guillermo Kreutzer many, many decades ago. They were the ones that founded our school in Argentina. The first congenital heart surgery with cardiopulmonary bypass was performed in the hospital that I trained in 1936 in the Children's Hospital Ricardo Gutierrez. And in 1966, the first 100 cases with cardiopulmonary bypass were reported. Our school became relevant for the whole surgical community after the publication by Guillermo Kreutzer of this paper, which is called An Operation for the Correction of Tricuspid Atresia. He described for the first time, at more or less at the same time that Fontan, the atriopulmonary anastomosis to treat this disease. And he established the foundations of the current treatment for single ventricle patients. Guillermo Kreutzer trained in Brazil, in Sao Paulo, with Dr. Servini, Professor Servini. And when he came to Argentina and founded the Gutierrez Children's Hospital School, the impact was so big that many people wanted to come and train with him. And somehow the pathway is different. It happened that from med school, directly, a doctor could enter a formal residency in pediatric cardiac surgery from the very beginning. So we do not have a residency that comes from general surgery or from cardiovascular surgery. In fact, in my case, I operated on my first congenital cardiac surgery when I was 25 years old after med school. In some way, this has advantages. I think it had advantages because at that time we had many more patients in which we could at least train simple congenital heart defects, I would say like PTA closure, atrial septal defect. Now, this model is not suitable anymore because the complexity of the congenital heart defects and the rise of the percutaneous closure of these defects leaves our residents with very few cases, I would say low complexity cases, to start their experience, surgical experience. So what was really important for us, because I'm 48 years old now and have 23 years of experience in the field, but it is not suitable anymore. So things are changing right now, and we are moving towards the usual pattern, which is med school, general surgery, cardiovascular surgery, and then pediatric cardiac surgery. So this is the model that we are adopting right now. After this first explosion during the 70s and the 80s, the program produced all surgeons who founded all the major Argentine pediatric cardiac centers across the country. Leaders include these are very important names: Dr. Schlichter, Dr. Laura, Dr. Gutierrez, Dr. Vargas, Dr. Antelo, Bohelfang. And this created the first cohesive national network of congenital heart defect. And this is the core of the Argentine school. One center that trained the leaders of the different other hospitals and centers across the country. The Argentine school continued to produce surgeons, new generations expanded the program, and what you can see in the picture is one large image that is on one of the walls of the Children's Hospital. And what I marked there in red is my name. And you can see that all the residents from early 70s, which are depicted there with a very small plaque, which outlines the years in which those surgeons were training there. So there is a tradition of learning, and there is a very big and robust school that continues to work actively. But of course, there is not only Argentina. We also have Brazil, Peru, Colombia, and Chile with very important surgical schools. Brazil, for example, has a long and prolific history of surgical training and innovation. Very, very famous names were born in this school. It has an officially regulated 5-year cardiovascular surgery residency, and during the last year, the resident may choose to focus on a specific area, which includes also pediatric cardiac surgery. The INCOR, the University of Sao Paulo, offers a formal program in pediatric and congenital cardiac surgery, which has as a prerequisite a completed residency in cardiovascular surgery or pediatric surgery. And there are other major Brazilian centers, such as the Dante Passanesi, for example, which also include exposure to congenital cardiac surgery. It's important to say that uh, even the people coming from Brazil, they say that themselves. There are two Brazils. One is along the coast, which has very, very large centers, a lot of experience, results comparable to developed countries. And on the other side, you have the inner part of the country, in which the numbers are different and the results are different. So there is an extreme difference between regions inside the same country. Regarding Peru, Peru has one of the largest centers in Peru, performs around 600 pediatric procedures per year within a high volume training environment. And the subspecialty in pediatric cardiovascular surgery at Universidad Peruana, Cayetano Heredia in core, which is a defined postgraduate program developed within the institution. So it works very well training surgeons from that country. Colombia is one of the most important countries in the region, and again, follows the general pathway, usually general surgery, then cardiovascular surgery, and then there is a post residency formation with training or a fellowship abroad, or 1 or 2 years of pediatric cardiac surgery. Some surgeons and cardiovascular surgeons complete additional training in other countries such as Brazil or Argentina, the US or Europe, especially for those complex cases, neonatal cases. And the reference centers is the Fundación Cardioinfantil from Bogota. Chile has more or less the same training structure: general surgery, cardiovascular surgery, and then pediatric cardiac surgery in a major pediatric center. Some other surgeons from other countries, such as Bolivia or Paraguay or some other regions, Ecuador, they also train in Chile, of course, in Argentina and Brazil. And they are more structured, I would say. Everything is more centralized in Santiago, which is the capital city, and they contributed with a lot. They contributed a lot to the specialty. The first extracorporeal circulation in South America was performed also, for example, in Chile. So, and some surgeons, even from Argentina, have gone to work on Chile because of the, I would say, the better conditions of the country as compared to other regions. The main centers in Chile are the Hospital Maquena, the Clínica Los Condes, and Hospital Sotero del Rio. As I said, it's a more uniform and structured environment than other South American countries. They have an very good integration between the universities and the hospitals. and they have access to modern technology as compared to other countries. The weaknesses is, as I said, it's very centered in Santiago. So the country has a very particular shape in terms of geography. It's very long and thin. So some regions are very far away from the capital city. So it's that is a problem. And they also have a few surgeons. They are enough to treat the whole population, but they are because there are not too many, but there is a small number of surgeons. The rest of the countries, Bolivia, Ecuador, Paraguay, Venezuela, Guyana, the other countries face more challenges than the ones that I mentioned before. For example, Uruguay, I didn't mention Uruguay. Uruguay is a very small country. It's very close to Brazil and Argentina. It's 1 hour from Argentina. So some surgeons go there, and Argentinian surgeons, and they also have their own surgeons. So it is the population is covered, okay? But for Bolivia, Paraguay, Ecuador, Venezuela, and Guyana, the situation is very difficult. Families report that travel distances, indirect cost, and long waiting times are the major obstacles. Remember, we have a geographically a complex region. There is a forest. There are very big mountains. The Cordillera de los Andes. So geographical barriers are a huge problem. Of course, the systems in those countries do not work very well. There are many patients that cannot be treated. There are system level barriers, which include the lack of local specialists like cardiologists and also surgeons. The ICU capacity is very limited, and there's no network. I was in Bolivia a week ago, operating on two patients, very complex patients. I was there with Dr. Erika Perez Albrecht. She's in La Paz. She's the head of the unit of cardiac surgery in La Paz. She's doing an amazing work in a very limited resource setting, and she manages to operate on some kids, but many patients from the country from that country do not receive proper treatment. Some of them travel, for example, to Argentina or to Brazil to receive surgery. And we have the same happens in countries like Paraguay, for example. We receive at our hospital in Buenos Aires many patients coming from those countries. In fact, I remember one case of a mother that took her very small kid, 2 months old. The baby was dying, and she took a commercial flight, arrived to the airport. At the airport, doctors resuscitated the kid. He was put into a helicopter, and from the helicopter directly to my hospital, and we entered the patient directly to the OR. So, but those are personal stories of resilience of mothers that choose to move and to try to look for help in other countries. But the situation, overall situation of those countries is very is critical. So the chances of receiving surgery are very limited in those countries. And what sometimes can be found is a centralization of services in a few cities, for example, in La Paz in Bolivia or Asunción in Paraguay, and the inequity and the disparities, geographical and socioeconomical disparities are the rule. There is an uneven case detection. There is a lot of work that has to be done in screening. Many patients never get a diagnosis. Uh, Remote communities never get access to doctors. There is a lack of not only professionals but also healthcare workers that can come to these regions and then kind of screen the population, even using basic tools, or do an X-ray, or an ECG, or those things are lacking in the region. There are, of course, NGOs and visiting teams. The missions play a critical role, but the trend is and has to be towards strengthening the in-country capacities and the cooperation between our countries in the region, considering them as one single uh, region, one single country, I would say, we share the same roots, than merely mission-based models. Because at some point, the local resources have to grow and need to overcome all the obstacles to establish proper local programs that can help the patients of their own countries. Well, and as take-home messages, remember that South America carries a heavy burden of congenital heart disease and deep inequalities in access to care. And even with limited resources, the region has been able to produce important innovations and diverse training pathways. Argentina, Brazil, Colombia, and Chile stand out for their strong mentorship tradition. These countries have a high surgical complexity and a culture of learning through practice. The training is strong. And what we need and what we envision is a future in which regions can come together, these countries can come together in a coordinated effort, regional effort, to share training, to share data, to use telementoring, simulation, and other modern tools such as AI to try to reduce the inequalities and give our populations and our kids the best possible uh, screening and surgery in those cases that is needed. Thank you very much for your attention, and I'm open to your questions.
Ignacio, that was a amazing overview of pediatric cardiac surgery in South America. I think he's online. Hi, Ignacio.
Yes.
Hi, Sean. How are you doing?
Good,
Nice to see
good.
you all, and thank you for the opportunity.
Yeah. Any questions? Dr. Colungos has a question for you.
Excellent presentation, as always, Dr. Lugones, and very happy to see you on the screen. A question is out of the region of South America, but what things are going on in Central America? Because there is the legacy of Castaneda in Guatemala, but what is happening, in Nicaragua and Panama?
Well, as far as I know, in Central America, the situation is more or less the same that we have here. The inequalities and major regional uh, differences. Okay, for example, Mexico has a very strong school, and Aldo Castaneda trained many of the surgeons that are not only in America, in Latin America, but also some surgeons from even from Europe that went to train with him. He was so famous that attracted many other surgeons. But the disparities in the central region of America are more or less the same that happen in in South America. Okay, in fact, uh, my talk was about South America, but it, the region should be described as Latin America, including Central America. So we share more or less the same roots, and we are, I would say, it's a completely different story as compared to North America. Okay, so the situation more or less applies is more or less the same. As I said, discrepancies, and some regions get attention, and the patients have some reference centers to which they can go and have treatment, but many other regions are undercovered.
Yes, because I remember I invited many years ago, I believe it was the 4th Global Forum Castaneda, and he came to Geneva and he presented what he was doing in Guatemala. And I was impressed because he presented his project regarding the creation of a training center in Guatemala, and he told that he would like, to operate, to train, all the necessary number of surgeons, pediatric cardiac surgeons, to able to cover the needs of Central America. And for this reason, I asked this question, if it was achieved this goal after him, if there was, continuity in the project, and you are not aware.
Yeah. He's well. Thank you. It's Aldo was one of the. Well, as I said, our region produced many outstanding surgeons, and many outstanding operations. Also, I always say that. Some examples are, for example, that the Chaten operation should not be called the arterial switch operation. It should call the Chaten operation. And sometimes when the contribution does not come from, let's say, central developed countries, sometimes even the names change. So, but everyone recognizes the contribution that, for example, Dr. Kreuzer has made, and well, Dr. Chaten, of course, and we have very good examples out there. Well, in fact, the cone operation described by Silva. We have many contributions. So our school, we are proud of our school. But as I always say, our region is like this. It's like it's unpredictable and uneven.
Yes, thank you very much.
Ignacio, thank you. Just one other question. You have amazing surgeons, amazing leaders, amazing innovators, including yourself. Is it a lack of being able to get young talent to come fill it, or is it just a matter of numbers?
You mean the number of surgeons? Or,
the number of centers, meaning you need more centers to develop more surgeons.
Yeah, it's more related to the whole situation. I would say the economic situation of the region, the development of the region. So it's not only the lack of cardiac surgeons, pediatric cardiac surgeons, but also the lack of doctors in general. So it's not only that. The numbers of surgeons in some of these regions, like Bolivia, Paraguay, and some of those countries that suffer more the burden of congenital heart defects, it's just a reflection of the smaller numbers of healthcare workers. Okay, it's just that the reflection. Okay, there are fewer doctors, and of course there are fewer congenital cardiac surgeons, and those that have the willingness of training in this particular field, they have major obstacles. As I said, for example, Erika Perez Albrecht from Bolivia, she has an outstanding story. She went to Chile to train, and she did a lot of effort leaving her country and then coming back and trying to establish a program. So everything is, you have to create everything from scratch. So it's completely different. So some doctors choose other pathways and they focus maybe on a clinical aspect. So it's much more difficult. The effect is a multiplying effect of difficulties and barriers. That is the problem. Not only the small numbers, but everything is affected. The creation of programs and surgeons and healthcare workers.
That makes sense. More of an infrastructure type program, more issue than just numbers. So thank you again, Ignacio. Nice to see you.
Thank you.
And thanks for giving the talk.